Hi, and welcome to the Inside Angle podcast by Solventum. I am Michelle Bedore, Manager of International Clinical Content Development here at Solventum. I have the pleasure of introducing Dr. Patricia Saleeby, who has earned a PhD in social work from the George Warren Brown School at Washington University, an MSSA in nonprofit management from the Mandel School of Applied Social Sciences at Case Western Reserve University, and a BA in biology from Oberlin College. Dr. Saleeby is the department chair in sociology, criminology, and social work at Bradley University. She is a recognized expert in the area of health and social care classifications, most notably for her involvement in the development and implementation of the World Health Organization's International Classification of Functioning Disability and Health, or ICF. She co-chairs the WHO Functioning Disability Reference Group. She is a member of the PACIO and Gravity projects that focus on post-acute care, social determinants of health, and health interoperability. Her work has been funded by the Centers for Disease Control and Prevention, the National Institute on Disability and Rehabilitation Research, the American Psychological Association, and the National Center for Health Statistics. She is a member of the Coalition for Social Work and Health, as well as the current editor-in-chief for the Journal of Health and Social Work. Welcome, Dr. Saleeby.
Thank you so much, Michelle. It's an honor to be here.
So let's talk social determinants of health today. As we know, where we're born, grow, live, work, and age, and our access to power, money, and resources influence our health outcomes more than genetic influences or healthcare itself. So this is something WHO reported on their World Report of Social Determinants of Health. Can you comment on this and its importance?
Absolutely. As you already articulated, social determinants of health are crucial because they significantly influence overall health and well-being. And when I mention health, I'm thinking and defining it very broadly. So it's physical health, mental health, behavioral health, and so forth. And social determinants of health encompass essentially the conditions in which, as you mentioned, people are born into, where they live, where they work. These are factors that can either promote good health or create barriers or hinder good health. So they're essential for achieving health equity and improving overall health outcomes. And this is at an individual level, family or group level, community level as well. In terms of that report that you mentioned, to give a little bit of background, the World Health Organization established a Commission on Social Determinants of Health. I believe it was back in 2005. And the intent or the aim was to determine what are those social factors that contribute to poor health and health inequities. And after several years, and you mentioned that report, which was commissioned, I believe, in 2008, they had three overarching recommendations. The first was how we were going to use social determinants of health to improve daily living conditions. So not just health, but overall, because we know there are direct links between, for example, housing insecurity, food insecurity, crime, social economic status or poverty with daily living conditions and health. Two was to tackle that inequitable distribution of power, money, and resources, knowing that all three of those are essential to understanding what goes on in people's lives and inevitably also affect health. And the third was to measure, understand the problem, and assess the impact of any actions that might be recommended from that particular commission.
Fantastic. Thank you. So I think a lot of people are confused about SDoH and the acronym. What does it stand for? So I think it started with social determinants of health, as we've discussed already today. And I think US has started to shift to call it social drivers of health to perhaps more accurately reflect the outcomes that are not predetermined. Like social determinants just means like it's a certainty. So I think there's been a shift to social drivers of health, but now I'm hearing structural determinants of health being added. Can you help us understand that, please?
Sure, absolutely. Social determinants and social drivers, I think, are used interchangeably. I mean, I know they are used interchangeably. And the shift really represented the fact that these conditions, these social conditions, as we've mentioned, drive healthcare outcomes. I know determinants essentially for many people, it's the same, but understand it that these are drivers. Perhaps it's used more in the economic sectors of the world, but understanding that there are societal, economic, and political factors that intertwine, and this in turn is what shapes health outcomes. In terms of structural determinants of health, which is relatively new, the idea is we want to move beyond just social factors and understanding that they exist and we need to address them if we're going to actually achieve health equity and improve health outcomes. But understanding that it's not such an easy process because many of these things are embedded in our actual structural systems. And things like poverty, inequality, discrimination, these all influence individual and population health outcomes because you have created these systemic barriers that are very difficult to break down. And you essentially have these social hierarchies, if you will, and it's difficult, even if you're working at a macro level, which is a lot of what I do, to be able to redistribute resources, for example, or end inequality or inequitable policies that exist, perhaps in an institutionalized setting. So, really difficult to be able to tackle these structures that inevitably impact health outcomes and the social determinants of health that also drive what we're seeing in terms of health equity and health outcomes.
Great. So examples of this could be things like the health of indigenous versus non-indigenous people of African descent throughout Americas, the Australias, things like that. Maybe.
Absolutely. Those are population groups that might experience social and structural determinants of health to a greater extent. Everybody, regardless of your identities, your social identities, experience this. It could be experienced on a temporary basis, it could be experienced on a longer term basis. But the idea of structural determinants really encompass those social and political structures that maintain or even promote the social hierarchical system and those inequalities that contribute to what we're seeing in terms of health inequities. So, structural determinants, for example, could be the way that your government in a particular country is structured. It can be, and it often is related to economic policies that are in place. It can be regulations around distribution of resources. So, these are things that are a little bit more difficult to tackle than, for example, we have a food insecurity issue in our school, and we know that once we identify perhaps what is contributing to it, we can perhaps more easily address that situation. But if it was embedded within that school district policies, it would be more difficult. We need both. We need to address the low hanging fruit, as they say, which would be more in line with social determinants, and also the structural determinants of health to make more sustainable and longer term outcomes achieved.
Great. So things like social norms, government policies, healthcare policies, regulations, all of these things need to be involved.
Absolutely. The interesting thing is that for years, we have different professions that have addressed this. Social work is absolutely one of those professions. Now we have medical and healthcare systems addressing it because we haven't achieved the health outcomes that we hoped we would. There had to be something else. And so the missing piece of the puzzle really has become the social determinants of health. And now, more recently, as we mentioned, the structural determinants of health. Until we're able to look at this and look at it across sectors and disciplines, we're not going to be able to address it correctly. We can no longer just work within our siloed profession to make this happen. It will take collaboration, it will take cooperation, it will take communication between sectors and disciplines. And there are already good examples of this happening. When we're able to come together, we're able to actually achieve success.
Yes, there's so many different players in so many different care settings. Like you mentioned, the value of the social worker. Now we have other people addressing this as we need. It should be something throughout that care continuum, but We have community health workers, we have patient advocates, we have care navigators, referrals to community-based organizations, food banks and shelters, and the doctor themselves, the person who rooms them, assessments. There's so much across the care setting. So I'd like to start really with the value of the social worker. I think historically this has been their role. We need more role clarification because someone can always think, oh, the other person took care of this, collected this information, talked to the patient about it, and how to alleviate these inequities and address their needs.
Absolutely. So, social work has a longstanding history in helping individuals within their communities. So, when we think about in the United States, where we saw this happening, people like Jane Addams out of Chicago, who created an organization called Whole House, understanding that we need to meet people where they're at, she went out in the community, and others who were women primarily who were looking at dire circumstances in those communities and wanted to help. And she, at that point, we weren't calling it social work, but she played a key role in making sure those services were being met and then started advocating for social reform. And that is where the start of our social work profession really began. So, from the very beginning, we were addressing social determinants of health, and we have continued over decades to refine how we do that. You mentioned some other important professions that are involved in looking at social determinants of health. Community health workers, we're seeing more community health workers help us provide resource and referrals to patients in healthcare settings and with the community. Social workers work with community health workers. We also take on that role or title of community health workers. So I think we're going to continue to see a very successful partnership in the future. Social workers are also patient advocates, but there's other people who are not social work trained who fulfill those roles. Same with care navigators, like, for example, breast care navigators are very commonly used in healthcare systems. So we're seeing some different titles that may or may not be an actual social work trained individual fulfilling those job roles. It may be others as well. It will be interesting to see what the future holds. I think that we will need to determine a little bit more what role goes with what particular title, who is responsible for what. But ultimately, what we're trying to do is improve health for individuals and communities.
Sure. And we see this globally. It's not just the US, that role clarification. This one puts it on that one, the other one puts it on this one. We don't know their training, we don't know their licensure, their credentialing. The doctor thinks before the patient gets to them that it's been addressed, may or may not have been, because someone who sees that patient before they get to the doctor may think this is the doctor's responsibility. So role clarification is pretty necessary, I think, everywhere.
Absolutely. Community health workers actually are more commonly used, I believe, outside of the United States. It's a more grassroots oriented profession. But here in the United States, we're seeing an increase and regulation around that particular job position. Social work has been heavily regulated for years. We have our Council on Social Work Education that maintains that all social workers must meet the basic competencies to actually be a social worker. And in many states, you can't call yourself a social worker unless you have appropriate licensing. And that requires additional hours of training to be able to understand what the role entails and be able to effectively implement those job tasks.
Great information. So, really, no matter where on the globe we are, we need the collaboration and we need learning to help create this paradigm that makes everything equitable and accessible for everyone. Physicians and other care providers, along with community resources, which is important, need to help the patients navigate their social challenges. Maybe they need assistance navigating, but the patients themselves have to take a part in this. Acting together, everyone help prevent and alleviate some of those inequities before they get to the point that they're complex conditions that can help everyone. We don't want to wait until the homeless person has to call an ambulance or have an ambulance called on them to go through the ED. We want to help them before it gets to the state.
That's absolutely correct. And we're hearing more and more of those stories, which I think is why we're seeing the momentum around social determinants of health, because we know that for a sizable number of people why they're actually going to emergency rooms, urgent care, why they're sick, if you will, is not because of a health reason. It is because of something that falls under social determinants of health. So if we're able to prevent this from happening, we're saving hundreds of thousands, probably millions of dollars to a healthcare system. We are saving thousands and hundreds of thousands of hours of time and burden upon our health and allied health workers. Social prescription is something that we're seeing come into the US. It has been primarily coming out of the UK and other countries within Europe. But the idea that clinicians can prescribe not medicine, for example, what you would find in a typical prescription, but they can do social prescriptions where they're able to identify and refer an individual patient to as you mentioned, a community-based organization, to a social worker, to they call it a link worker, but social workers fulfill that role in many countries, but the link worker to be able to address what is needed. So it's an interesting take on what we would think of as a traditional prescription, but utilizing this. And interestingly, things related to social isolation and loneliness are things that can be socially prescribed. And we know that social connection is linked to improved health outcomes and reduced risk of early death. And that's something that has come out with a recent report out of WHO. So the idea of social prescriptions could be something that would take off in our country. I wouldn't be surprised if we don't see that happening.
I love that. And like you said, the loneliness and isolation, that's huge. That's huge on outcomes. Stepping back a little bit to the expense of it all, not just helping people get what they need, but if we look at, in the US here where we are, we hear that like 5% of the population accounts for 50% of the spending. I mean, that's large. Also, I know from work in Canada, their regulator said that almost 93% of their patients experiencing homelessness were admitted to the ED. And when they're homeless, they stay in the hospital twice as long with double the cost compared to the national average. I mean, saving money, that's important. Saving funding for something other than things that we can treat before it gets to that point, that's really big.
Absolutely. There was a report almost 10 years ago at this point, and the report indicated that about 93 billion annually in terms of excessive medical care costs of things that were driven by social determinants of health. So if we were able to actually prevent and address those social determinants of health, that we could reduce those excessive medical care costs. We could also, as we know, reduce the health disparities that lead to losses in productivity. So when you think about lost productivity, I think that same report mentioned it was around 42 billion annually in terms of those losses associated with perhaps someone not being able to engage in their job and the workforce participation due to decreased output as a result of being sick or having to go to the hospital, for example. So we know, and when we look at, of course, health inequities, there's a difference. When you look at groups that identify as, racial, ethnic groups, cultural groups, persons with disabilities, and so forth. So we know that there are complications and there's differences, and they're quite significant between these types of groups. And that also relates to some of the social versus structural, right, determinants of health. If we can eliminate those inequities, those health inequities between these various population groups, we're probably going to look at greater input in terms of premature death. We're going to look at greater outcomes related to preventing illnesses, also chronic diseases, and that probably equates to in the trillions of dollars. So addressing social determinants of health really is an investment, and it's a cost-effective approach to how we might reduce our overall healthcare costs and how we actually can improve the health of our communities and our society at large.
At the same time, that's key. So, as we look to involve more community based organizations like food banks and shelters, at least here in the US and probably globally, these resources, they're pinched. They have elevated needs, they have federal cuts. So, there's little resilience in the system. The Department of Agriculture cut 500 million from the Emergency Food Assistance Program. And, this is with Feeding America and other large food banks that have meal programs and, not for profit. these organizations are struggling now, and then with cuts, while there's an elevated need, it's a recipe for disaster.
It's very unfortunate. We're going to have to get creative and we're going to have to collaborate with one another. We're going to have to communicate. We're seeing a lot of coalitions coming out of this, a lot of social movements, which very much aligns with social work. And we also can share our stories, right? Share our challenges, share our positive solutions, our successes. I think this is absolutely important. There was a time, I think years ago, 'cause, working in with a lot of nonprofit organizations where people didn't want to collaborate because there was a lot of competition, right? Going after those funds. But I think the time has changed that we need to be more transparent and communicate that we are in fact having financial challenges, looking to the foundations that are out there, private foundations, family foundations. They are stepping up to fill the deficit, that gap that we're seeing being created by recent changes in legislation and regulations, things coming out of our administration at the federal and state level. So understanding that nonprofit organizations are going to be taking, and they're already taking, really sizable budget cuts. How are we going to help them stay afloat? How are we going to help them sustain when on the other end, we're seeing increases in those cases, the population groups of the clients being served and so forth. So really important that we share those impact stories with one another. We start to pivot in terms of our fundraising strategies and looking to private giving as a source. And as I mentioned, these foundations are stepping up. How we also need to engage our membership, our board members of these organizations, our key stakeholders, making sure that they're involved in key decision making and so forth. Our nonprofit organizations have to lead with strategy, not just waiting and being reactive.
Yeah, true. Thank you. So, this being such a global issue, we're all under the same sky. We have to address these factors, try to reduce these disparities, ensuring that all people have access to the care and the resources that they need to have their optimal health. How do you see this going? Just trying to get my arms around how big this problem is. We could probably talk for hours and hours. This is a short podcast, but like, how can we help measure this? Like, from what I'm thinking, we get the story in the documentation, and then if we get it coded, we could know what we're dealing with. There's coding problems and disparities of coding, who uses what code set and all of that globally. But if we get it in the documentation and then we get it coded somehow, we could like measure it and trend it, analyze it. That's where I'm going with it. How do you think we could just wrap our hands around how big this problem is?
That's a great segue because this is already being done. So many of us have had experience with electronic health records or the EMR, electronic medical records within a particular hospital or healthcare setting. We're seeing this more and more because we're going digital. We're no longer having paper-based systems, but those systems don't necessarily communicate with one another, and they don't track that information, as you mentioned, related to social determinants of health. But now we are building the system to enable to do this. There is something called FHIR, which is an acronym that stands for Fast Healthcare Interoperability Resources. It's that back end to all these digital solutions. And that PASSIO group and the Gravity group, that those two working groups that you mentioned, I'm involved with much more with the PASSIO than Gravity. Gravity looks at social determinants of health and how we're going to actually build it into electronic health records. So they're taking one social determinant of health at a time and determining how we can systematically pull that in so we can actually capture that data, which is pretty remarkable. The PASSIO group, which is the acronym stands for Post-Acute Care Interoperability, we're looking at how we can pull in functional information, knowing that diagnosis alone tells us very little. Let's say, Michelle, you and I have diabetes. We have the same ICD, which is the system, the WHO classification used for diseases, the same code, but our lives very likely are going to be very different. So we have to look at functioning and functional information. Now we have a way to pull that into the electronic health record as well. We're linking it all to a terminology and classification called the ICF, which is another WHO system that looks at functioning, disability, and health. It was something that I'm quite proud of. As a PhD student at Washington University, I helped to develop it. And working with clinical professionals, working with persons with disabilities and other key stakeholders, we looked around the room and said, how are we building a functioning classification to work with that ICD system without looking at the environment? And this is something in the late 1990s, something that predates what WHO later called social determinants of health. We built an entire section on the environment because there was no way to look at functioning and look at changes in functional status without environmental factors. So I'm quite proud of that, that history and that legacy, if you will, that has led to social determinants of health. But it's important that we have the systems and now we have the technology to be able to have it put into those records and to track it along the way. And I think that's going to be crucial, that we can collect the data, we can measure it and measure the interventions and the outcomes.
Thank you. I think this is a pretty good spot for us to stop for today, though I'd love to talk with you again about this. Collect, track, measure, improve. That's key. Thank you.
Thank you so much for having me. It's been a privilege.